And we'll just welcome everyone that's joined so far. Thank you so much for joining.
Yes, thank you.
Welcome again to everybody who's joining us. We'll begin in just a few minutes.
Hi, good afternoon, everyone. I want to welcome and thank you all for joining this event. This is the third annual Dr. Daniel Ian Kaufer Lecture. We are delighted that you're able to join us. My name is Sanjay Asthana. I'm the founding director of the Wisconsin Alzheimer's Disease Research Center and also Associate Dean for Gerontology at the UW School of Medicine and Public Health here in Madison, Wisconsin. This lecture is an educational program which is devoted to shaping the future generations of dementia care professionals and scientists. And we're really honored to be able to share the legacy of Dr. Kaufer with you all. At this time, I would like to invite David Kaufer, who's Daniel's brother, to share a bit about Dr. Kaufer's legacy and also some information about this lecture series. David, please take it over. Thank you.
Thank you, Dr. Asthana. Good afternoon, everyone. Nancy and my brother and Denise Haviland's partner, Daniel Ian Kaufer, strongly believed in a compassionate approach to neurology that combined research advancements with realism, placing utmost importance on the dignity and well-being of patients and their families. Above all, Dan emphasized the empowerment of family and lay caregivers through knowledge and training rather than disregarding or neglecting their role. The University of Wisconsin held a special place in Dan's heart as his beloved alma mater. When Dan faced an unforgiving cancer and imminent death 3 years ago, one of his final acts was to establish this lecture series to carry forward his vision and values. This lecture series aims to inspire future generations of neurologists, medical professionals, and caregivers of individuals with severe memory disorders. Dan's family is both grateful and humbled to have the opportunity to participate in this third Daniel Ian Kaufer lecture featuring Dr. Helen Kales. We would like to extend our heartfelt thanks to Steve Ramig, Cheryl Jean Spenceley, and Dr. Barbara Bendlin for involving Dan's family in the planning of this special event. Thank you.
Thank you so much, David, and thank you to everybody who's joining us today. It's wonderful to see so many familiar names, and welcome to everyone in particular who's joining us outside of Wisconsin. It's great that we can do this in the Zoom environment. At this time, I want to introduce our keynote speaker. We are so pleased to be joined by Dr. Helen Kales, who is the Joe P. Tupin Professor of Psychiatry and the Chair of the Department of Psychiatry and Behavioral Sciences at the University of California, Davis. Prior to joining UC Davis, Dr. Kales was Professor of Psychiatry at the University of Michigan, and that's where she founded the Program for Positive Aging in 2009, a program which moved to UC Davis with her transition in 2019. She's received extensive federal funding as a principal investigator, particularly in the area of interventions to help caregivers to manage behavioral and psychological symptoms in people with dementia, as well as in considering the use of psychiatric medications in people with dementia. She's recognized as a national and international expert in the area of non-pharmacologic interventions, in particular behavioral and environmental modifications to alleviate neuropsychiatric symptoms among people with dementia. And in recognition of her work in the field of dementia care, Dr. Kales was named to the standing Lancet Global Commission on Dementia Care in 2015, publishing numerous impactful reports in our field. As a board-certified geriatric psychiatrist, she's been included for many years in the Best Doctors in America list, as well as Sacramento's Top Doctors. So it is our sincere honor to welcome Dr. Helen Kales.
Thank you so much, Barbara and Sanjay, and I am just incredibly humbled to be asked to give this lecture. The mission and purpose of this endowed lectureship is so consonant with my values and my career, and I just want to thank the Kaufer family because I think that caregivers are such an undervalued resource in our country, and if dementia care is to truly move forward, we really have to turn to our caregivers and empower them, and moreover, give them the resources that they need to do the care that they're doing. It's a very silent but large group. And I have provocatively titled this, Agitation is Not a Disease, how we better assess and manage behavioral and psychological symptoms of dementia. And I hope you'll understand why I have titled this the way I have partway through the presentation. I just want to acknowledge some of the grant work and people power that have gone into the research that has been done, and let all of you know that I have no financial interest in the commercialization of the DICE approach, which we will be talking about today. What we're going to cover is what prevents families and people with dementia from living well, because that is really the goal now, is to help people to live well. Over my career, I've been able to see movement from, somebody gets a diagnosis and nobody talks about it and they're hidden away, to really this idea that people can live well with dementia. However, the behavioral and psychological symptoms can get in the way. And some of the issues that we'll be covering is coordination of resources, the lack of personalization and precision of dementia care, and our workforce. And we'll be talking about the DICE approach as a way forward. We'll also be talking about how we integrate medications into the approach, as well as the recent approval of a medication by the FDA for agitation. But before I begin, I was asked to give a little bit of a path, and I'll come back to this hopefully at the end of the presentation, but my path to this type of work started when I was young. Both of my parents are actually psychiatrists. And so I fought pretty hard not to go into psychiatry. I tried to think about everything else I could think about. I thought about OB/GYN, I thought about family practice. However, when I did my psychiatry residency, I realized that I felt good when I was waking up in the morning, and I felt a sense of purpose that I had not felt before. And I think one of the things that happened was on that rotation, I had a resident who integrated everything really well, the medical, the neurologic, the psychiatric, and that was what really made me excited. And so several years later, when I was in a psychiatry residency and I thought about subspecializing, I felt that geriatric psychiatry was a very natural choice. And come to find out, that same resident who had influenced me so strongly is now also in geriatric psychiatry. He's a full professor and endowed professor at University of Rochester, where I went. So I think that that path was made actual by a couple of things, not just the medical piece, but also the fact that my grandmother, who was a Greek immigrant with a sixth grade education, but probably the smartest person I ever met. She lived with us on and off growing up, and especially into her old age, and had some issues with depression following a stroke and then some cognitive impairment. So I definitely had that piece working with me. The other thing is, and this I really resonate with what David said, is that I really love medicine that is patient-centered. And I think that that is what we need to get back to in the field of medicine. There are a lot of reasons why we're pulled away from that, but I think that is where I feel that my true calling is, in both patient-centered and family-centered. So actually, this gives us a good overture into a case that we will be using as a background for today's presentation. And this is the case of Frank and Dot. Frank is a 78-year-old man who has moderate dementia. He lives at home with his wife, who is 75. So like many, she's caring for him in the home. He has what is a pretty typical medication regimen for an older person. He's on losartan, Aricept, Namenda, Ditropan, Metformin, and Simvastatin. And Dot calls with a very, very common concern one Friday afternoon at 4:30. Frank has been getting agitated in the past week. Can you prescribe something to calm him down? And so the primary care physician, wanting to be attentive, prescribes gabapentin 100 milligrams BID for agitation. Very common, and we will be coming back to this in a little bit. So one of the first big problems that we see with dementia care in the United States is that we have very few specialists. The wonderful folks online today are definitely specialists, but we specialists are usually concentrated in academic centers. And so if you go to places like Northern California or Upper Peninsula of Michigan, which was in the state I used to live in, there are very few people who've been trained in dementia care. And so our primary care physicians do a lot with a little bit, but typically they have very little training in dementia. And because dementia is more than a medical illness, it impacts all the spheres that we think about in terms of the biopsychosocial model, so legal, financial, functional. And resources are often available, but they can be hard for caregivers to find and access. So that kind of gives us our first big problem to think about. Our second big problem is that these days we are largely focused on personalized medicine and precision medicine. And personalized medicine, they're a little bit different. So let's just get on the same page, is treatment that focuses on patients based on their individual clinical characteristics. Precision medicine then identifies what treatment approaches work for which patients. And part of the issue with current dementia care is that we largely don't personalize or use precision medicine. So given that we currently have a lack of a cure for dementia, which is really a syndrome, not a single illness, our focus is largely on day-to-day management. And typically what that focus is on the often extremely challenging behaviors that accompany dementia. And it was so heartening to hear that Dan had focused his career on some of the difficult types of dementia that often really see a proliferation of these behaviors like frontotemporal dementia and Lewy body dementia. Our current real world care, whether it's in the community or long-term care facilities for behavior, largely focuses on medicating or sedating people with dementia. And so I want to contrast the way we currently assess and manage physical symptoms in an older person with how we manage behavioral symptoms. So if a family caregiver was to call their primary care physician and say, this person has shortness of breath, if the physician responded, oh, well, okay, I'll write for an antibiotic, we would all say that's malpractice because the physician has not assessed the underlying symptoms, hasn't asked about history, hasn't done a physical exam or any labs. And instead, what our primary care physicians do, and you're not meant to see this, it's just meant to illustrate the complexity, is they go through algorithms. So they think about what the shortness of breath could be caused by. Is it a pulmonary embolus? Is it heart failure? Could it be something else like an infection? And so depending on that clinical suspicion and what happens with the physical and the labs, they're going to go down different pathways for the treatment. Conversely, if a caregiver is dealing with a behavior, they will often call a physician and, as in the vignette, say, this person is agitated. Or they may be a little more prescriptive. I really need help to calm this person down. Or sometimes what we hear from our staff is something very specific. Can I get an order for this type of medication at this dose? And so often, instead of saying, wait a minute, I don't know what's going on, a physician will respond, because we've all been taught this in medical school, I'll write for such and such medication right now. And so again, I want you to think about how that differs from dealing with a physical symptom like shortness of breath. So I showed you the algorithm that primary care physicians use a few minutes ago for shortness of breath. Unfortunately, for agitation, it's not an algorithm, it's a straight line. So we hear agitation and we prescribe a medication. And depending on who you are or what evidence you read, it could be an antipsychotic, it could be a mood stabilizer, or it could be a tranquilizer like a benzodiazepine. And with the recent approval of this new medication, it could be increasingly this new medication, which I'll talk a little bit more about in a few minutes. So what's the problem with that? Why am I concerned about that? So first of all, medication isn't very effective. We've studied this, we've done meta-analyses, and we're really using 1950s treatment for 21st century patients. If you see the ad there on the right, that was from the American Journal of Psychiatry in the 1950s. And it was actually a 2-page ad. They paid for that, for a 2-page ad. And the question they were asking was, what are we going to do about Pop? And Pop is the gentleman who looks pretty angry there, and he's swinging a cane. And the answer was, we're going to give him Thorazine. So we're going to treat what's called senile agitation with Thorazine. And unfortunately, we're still doing that. So we're still giving actually the cousins of Thorazine, which have slightly better side effect profiles, but we're not really treating anything. We're often covering it over by sedating a person. And the problem with that is that medications are associated with significant side effects, including mortality. And that bottom table is work we did at University of Michigan, and we calculated the number needed to harm. And that is a number that means the number of people you need to treat to cause one death with the medication. And so ideally, you want that number needed to harm to be a very large number. And unfortunately, with medications like the antipsychotics, which are the medications listed there, the 5 top medication, or the 4 top medications after antidepressant, the number needed to harm ranges from 8 to about 32. And so that isn't very big. You don't need to treat many people to see a death. And with valproic acid, that at the time we did the study, which is called Depakote in its trade name, that was being used as a second-line agent. The number needed to harm is only 20. So again, the risk-benefit profile is not optimal. And so that becomes a problem, which our policy bodies saw, and they sought to curb antipsychotic use. So they were looking at all of this. The FDA created what are called black box warnings for the antipsychotics for people with dementia. And what happened was CMS, our Medicare and Medicaid national policy body, tried to drive down antipsychotic use. And we studied that and we thought, well, did that happen? And the answer to that is yes, but. So yes, antipsychotic use came down with this campaign. And that is, if you look at the chart The light blue circles in the middle of the graph, that's antipsychotic use going down from 2009, and it does continue to go down. But unfortunately, if you see the lines that are intersecting with those light blue circles, you will see that two lines are going up, and that is mood stabilizers and benzodiazepines. So what happened was that while the policy drove antipsychotics down, it also drove the use of other medications up. So we didn't see that physicians were trying to use person-centered non-pharmacologic strategies. Instead, they said, what other medications can we use that wouldn't be antipsychotics? And so if you look at that top line, that's overall psychotropic use. And that line has been fairly constant at about 70% of people in nursing homes being on psychotropic medication. So let's take a step back and think about what causes behavioral symptoms. This is a pretty complicated graphic, but I'll try to walk you through it. This is work we did for an NIA, National Institute of Aging, NIMH consensus conference. And what we believe causes behaviors in people with dementia, no matter what type, is two different pathways. The first being a direct disruption of brain circuitry. And that could be with a symptom like apathy. That is a pretty direct effect of certain brain circuits being knocked out. However, with many other symptoms that we see in dementia, that is actually the result of the person with dementia being increasingly vulnerable to stressors or triggers, meaning that their threshold to express a behavior is lower than would be for all of us. So, I might get mad at somebody at work, but I have certain gating mechanisms in my brain that keep me from, striking out at somebody or hopefully losing my cool. Somebody with dementia may not have that ability. And so let's shift to the bottom. What we see are factors there in 3 different boxes that can trigger behaviors. So within a given patient, an acute medical illness, and they might develop an acute confusional state like delirium, pain, which is often under-recognized in people with dementia, pre-morbid personality issues or psychiatric disorders, and then a really big one, unmet needs. So people who are overtired or hungry or bored or scared may express behaviors. Then in the middle, we see our caregiver factors. So what's really important to consider is just like in child psychiatry or pediatrics, we have another person here who is in the mix. So we have our person with dementia, but often they are accompanied by a caregiver. And we know from research that if a caregiver is distressed or depressed or fatigued, that can get mirrored in a person with dementia. So it's important to think about that as well. Often caregivers do not receive a lot of education about dementia. I'm sure at wonderful centers like at Wisconsin and, at the center I worked in Michigan, we really work to educate people. But often I'm told by caregivers, I was given a diagnosis of dementia for my loved one, and we were given a prescription and we were told to come back in 6 months. And so not having the education necessarily on dementia and the stages of dementia can be a real issue for caregivers. Another one that we are studying very actively right now through one of my mentees is caregiving styles. So similar to parenting styles, we believe that there are a certain number of caregiving styles. There are those of us who, not myself, but others who are naturally good caregivers and empathic and know what to do and are just really one of those folks who just sort of anticipates before a problem. And all the way at the other end, there are people who may get easily upset or tend to externalize or experience things as barriers. And so we need to work with all those different types of caregivers to figure out what's going to work for them. And then lastly, we have factors in our environment. So environments can be over or understimulating. There is often a lack of light in places where people with dementia live. One of my colleagues who does this type of research has researched that in homes and assisted living facilities, there's often about 1/3 to 1/5 the amount of light that is needed to entrain our circadian rhythms. And those are important for our mood, for sleep, and our functioning. And so we often think, oh, let's dim the lights and let's have, low stimulation. But in fact, that prevents people from getting the kind of light that they need to really help their memory and their mood and their sleep. Lastly, I just want to touch briefly on COVID. COVID affected all of us, there's no question, but our people living with dementia were among the most affected because people in nursing homes actually, because they didn't understand or couldn't wear masks or wouldn't wear masks, in some cases, they were locked into their rooms and locked into their wards. And this created a lot of difficulty behaviorally. And we actually saw a recent study showed a worldwide increase in sedating medications, particularly antipsychotics during COVID. So just to underscore how much this impacted people living with dementia and caregivers. So given all of what I've articulated so far, does it make sense that we treat people with a brain disease and all this complexity when they express a behavior and we, without looking at it, without thinking about it, give them a medication? And that's what I'd like people to reflect on. So some colleagues of mine who did a trial about a year or so ago where they were looking at mirtazapine or Remeron for, quote, agitation, wrote the fundamental presumption that there is a single neurobiological basis for agitation and a specific drug that it will target it is particularly weak. And what they underscored, and we've recently underscored this in the Lancet panel, is that we need to use non-pharmacologic person and caregiver-centered responses that investigate underlying causes and tailor our responses to behaviors like agitation. So I just want to say a word about the new drug that was approved. We talked about it at the recent Lancet panel, and this was approved by the FDA. It's the first drug to ever be approved for agitation. And why would I be concerned about that? Well, there's a couple reasons. They used an expanded definition of agitation that was never meant to be used in a drug trial. They also had the bulk of their study population from sites outside the US, and this resulted in a study population that was about 96% Caucasian. Now, the problem with that is here in the United States, we have a very heterogeneous population, and research has shown us that people who are African American often tend to receive both more antipsychotics and higher doses. So this is concerning. And then lastly, if we isolate the results from the US populations, the trial was pretty negative. The last concern we have is that prior studies for risperidone and aripiprazole actually probably showed greater efficacy, but for some reason the FDA did not approve those drugs for this indication. So it appears to be a shift on the FDA's part. And I'm not concerned that people will use this drug for really refractory cases. What I'm concerned about is that there will be increased use of this drug without any assessment of underlying causes. So we'll talk about that. I've talked a bit about non-pharmacologic strategies, and part of the issue with that is every first-line body, whether it's national or international, says these are our first-line treatments, but they've largely not been scaled to clinical settings that real-life patients and their caregivers go to. Part of that is the time they require. It's simply easier to write a prescription. And part of that is that people are bewildered by what strategy do we use and when and what is effective. So largely we have this big problem with a lack of training among caregivers and providers on how to use these strategies. Let's talk a little bit about the evidence though. The evidence for these interventions, which are for family caregivers, training family caregivers, is actually better than for any medication currently used for behaviors. The effect size is larger. That was shown by Brodaty's meta-analysis of 23 randomized controlled trials a few years ago, where they looked at the impact of training caregivers on the frequency and severity of behaviors, but also on how caregivers felt, their well-being. So it's not only larger than any medication, but the effect size is actually larger than the medications we use to enhance memory. So that's pretty compelling, but again, hasn't received a lot of uptake. So what do we train caregivers to do when we talk about training caregivers in these interventions? We teach them to problem solve, to manage behaviors. We work with them to increase tailored activities for people with dementia. We work on communicating between the person living with dementia and the caregiver. We work on safety and reducing environmental complexity. And we work on simplifying tasks depending on where the person is at the stage of dementia. So these are the big problems I've articulated so far. How do we solve these? And we thought about this a few years ago. And what we did was we convened a national conference of experts across the disciplines. So we had people from psychiatry and medicine and social work and nursing and psychology. And we talked all day about what an approach would need to contain. And mostly that this approach would need to help us avoid that type of prescribing without thinking about what's underlying the symptom. And what we came up with was the DICE approach. And I'll just walk you through this. So the D stands for describing a behavior that challenges. We want to know who was there, what happened, where it happened, when it happened, and how it happened. And that's because those are all clues to what could be underlying the behavior. We then take those clues, we encourage our caregivers to think like detectives and explore possible underlying causes, either in the person with dementia, the caregivers, or the environment. We then work together to create a collaborative prescription. So we're going to think of several strategies that could help us manage the behaviors. And then lastly, after we try these for a couple of weeks, we want to evaluate how well they worked. So why does this approach work and why is it different? It's designed to be easy for caregivers to remember, to create good habits. We train them, for example, to assess pain in people with dementia. And it integrates thinking about medications, both for the symptoms themselves, but also underlying causes like pain and infection and constipation. And then we tailor the strategies to the person living with dementia, the caregiver, and their environment. So I want to go back to our case. If you remember, this was Frank and Dot, and she's calling to get a prescription. So our first step will be to get from Dot a better description than agitation. When somebody tells me agitation, I really don't know what that is. Again, it would be like treating shortness of breath without really understanding it. So we teach our caregivers, this is a little depiction of the Wizard of Oz at the bottom. We train our caregivers, can you play the behavior back for us, like the scene from a movie? Who was there in the scene? When was it? Where was it? And what happened? So I'm going to play you a scene now, and I want people to watch this, and I will take it from there after we play the video.
Frank, you haven't touched your lunch.
I already ate.
No, you didn't. You didn't eat a thing. Now I want you
Leave me
to...
alone.
Frank, you have to eat.
I've eaten.
Frank, your pills. You haven't taken your pills.
Go away. Those aren't my pills. What are you trying to do to me?
You have got to take your pills now and eat your lunch. What is the matter with
I'm
you?
leaving.
What?
Go to the car. Where's the car?
No, you don't. You are going to take these pills. You are going to eat your lunch, and you are going to take your bath. What is the matter with you?
So this is a pretty common type scenario. And I just wonder if people in the chat might be able to type what they think might be happening. Again, if Dot called and said agitation, she might get a medication, but do we see some things here that we might remedy without medication? Are there some clues to what might be going on in this couple? So I'm not sure if I can see the chat, but maybe if Dr. Benlin can see it, if anybody can type in what they might see as some clues that would be, oh, somebody said the chat is disabled. Okay, well, I guess we will not do that then, Dr. Benlin. But I would say that there are a lot of things here that hopefully you have noticed and that can help us in thinking about some modifiable strategies. And you would see that, again, we need to hear more than Frank is agitated. So if we go and we first start describing the problem, when we come into the room, we notice that Frank is staring into space. He's holding his left upper chest, which we want to think about a little bit because that could be the sign of something. He tells Dot that he already ate. He says to leave me alone. As she kind of escalates, so does he. And I hope you noticed that he starts to get more escalated, more angry. What are you trying to do? That almost becomes physical then. I'm leaving, and he throws the tray over. Now, again, we are not in any way disparaging Dot, but she comes into the room and it appears like she's already very stressed. We don't know what else is on her plate, and that would be important for us to figure out. But she already comes in pretty overburdened. She's on edge. She says, "You haven't touched your lunch." She then argues a little bit with Frank when he says he did. And then she says, "What's the matter with you?" Again, not at all to disparage Dot. These are very, very common responses. In terms of the environment, we see him sitting in front of the TV with his blanket and tray. The room is somewhat dark. So we then want to go on to our investigate step. We want to think about triggers from one of the three categories: the person with dementia, the environment, or the caregiver. And within the person, some very common sort of low-hanging fruit are pain. So holding or rubbing part of the body, some other non-physical signs of pain, constipation, urinary tract infection. Another big one is recent changes in medication. So often a recent change in medication or a new anticholinergic medication like Benadryl or Tupin can cause behavioral issues. Within our caregiver, note that research has told us that reacting harshly or in a confrontational way can increase behaviors, offering too many choices, being very stressed, and then, of course, considering our environment. So here we investigate, we find out that Frank has no psychiatric history. He is holding his left upper chest, so it would be important for us to assess for pain of some type. He's taking Tupin for incontinence, so could there be any anticholinergic effect there, which can cause confusion? If we remember he has type 2 diabetes, we should find out whether his blood sugars are under control. And we should always ask about safety. Is his safety at risk? And you'll notice that there were some tripping hazards there, and I'd be a little worried about falls. For Dot, we noticed that maybe her communication style may not be optimal. So starting out with the negative tone, being critical or confrontational, we train our caregivers that even though it's very tough, trying to counter that impulse can really get you further down the field. We need to work with her to see if she could be depressed or lack sleep, and really work with her to educate her about the dementia stages. So if you'll notice, she gave a lot of what we would call multi-step commands. And for somebody at Frank's stage, that can be very confusing. We also want to find out if she is a sole caregiver. Does she have any respite or other family that can help? And what resources is she using? And then, is her safety at risk? We need to ask about this. Frank is a lot bigger than her. So has she ever felt threatening, or has he ever struck out? We need to really know about that. Lastly, with the environment, we see again the tripping hazards, a lack of structure or cueing, and then there's that lack of light that I mentioned. For our create stage, we pick from 6 general pockets of strategies. We want to manage any physical problems we see, provide staff or family education and support. We want to work on communication with the caregiver and the person with dementia, create meaningful activities. So again, I think a lot of our activities, we tend to think of sort of one size fits all, but we want to find out what Frank likes and what he doesn't like, what he's interested in, and what are some things he can do. So then simplifying tasks and then ensuring the environment is safe. So with Frank, here are some possible create strategies we might use. We could work with his primary care physician to consider replacing Ditropan with a more bladder selective agent. We might want to think about if low blood sugars pre-meal could be triggering some irritability and maybe scheduling some snacks if lunch will be late. With Dot, we want to work with her on dementia stages and effective communication. We sometimes train our caregivers to think about playing the role of a calm caregiver. And I always give as an example, as a parent with my kids, often what I found is that a very negative or critical tone was not helpful, especially when they became teenagers. And so really working on the tone with them was helpful. Setting the stage for any activities with communication, letting people know what's coming and what's going to happen, getting respite, and then making sure she feels safe. With the environment, we want to create routines and activity for Frank around his meal times. So one thing we tend to do is ask caregivers, could he help with meal prep? Could he help make sandwiches? Or could he do things simply that helped him start to cue into what the next activity was? We also want to make sure he's getting that natural light to know what time of day it is, and avoid sitting him in front of the TV if this is not of interest. I have a lot of people with dementia who actually, when you sit them in front of the TV, it can be disturbing or overstimulating. And then lastly, let's remove any safety or tripping hazards. After we try these strategies for a week or two, let's not forget to evaluate. So in a clinical setting, we might use something called the neuropsychiatric inventory. This is an example here of the NPI-Q, which is a quick version of this. What's nice is we also, on this form, we measure caregiver distress, which you really want to see coming down as you're trying different strategies. However, what I find clinically is using a simple measure of severity and frequency is often very useful. So she might give us that something is very severe or daily at the beginning, like a 4. And what we'd hope to see over time with our strategies is that number would be decreasing. So we'll also evaluate with Dot what we tried and what we didn't try. Did we try different medication for the bladder or for blood sugar? Did we try to work on communication? Did we use respite care? And what new routines we tried? So we've now created the DICE approach. What did we do next? Well, we created some trainings. This was back when I was in Michigan. And we did statewide trainings in several different areas, and we did a mix of family and professional caregivers so that they could talk to each other and share. A number of our professional caregivers were also family caregivers. And this is just the paper that resulted from this, but we found that training significantly improved what caregivers felt was their confidence and ability to manage behaviors. We then took those trainings and got additional funding and created a website for caregivers where we train them to do the same thing as with our in-person trainings. But what we heard from caregivers is we want this to be available to us anytime, anywhere, and we don't want to necessarily have to get somebody to stay with our loved one in order to get training. So now they can do this in their home. And since we have developed those, we have now done this nationally. I've just picked out a couple of locations in Washtenaw County, which is where the University of Michigan was. We trained all of the PACE employees, including the transportation workers, on this strategy. And we're now writing this up, but in adopting the DICE approach, they have found that they have decreased healthcare utilization, like emergency room visits and medication use, and have been able to be much more person-centered. In your state, Wisconsin, we have paired with the university there and Dr. Art Walasek to train care case managers across the state and DICE, and we now have a paper that is published on that. And we have been doing training now in my new state of California. With very little promotion or marketing, we also have over 600 caregivers who are now using our website. So we're looking to make this sustainable and be able to disseminate it. We have a new grant from the National Institute of Aging where we are training study champions in primary care clinics to use the DICE approach and then train family caregivers. And during this grant, they are working with the care partners of people living with dementia to work on care strategies. And in this grant, we'll be measuring medication use, hospitalizations, ED visits, and nursing home placement. So hopefully we'll have data for you on that soon. And I want to talk to you a little bit more about the use of medications. So I've alluded to medications. I've alluded to that they're a little bit of a problem in terms of knee-jerk use, but how should we use them within the DICE approach? So we use medications largely off-label in dementia. Is that bad? No, we do that all the time in medicine. It just means using a drug that is approved for one thing for a condition that it's not approved for. And so what we want to consider in each case with medication is a risk-benefit ratio. So for every person, does the benefit of using the medication outweigh the risks? The DICE approach does not prohibit the use of medications, but again, we want to counter against knee-jerk use and really consider risks and benefits. We want to consider everyone's safety first as part of the describe step. And if anyone's safety at risk, we should always urge people to contact somebody immediately. We urge medication use as first-line therapy in 3 cases, and that would be major depression with or without suicidal thoughts, aggression with risk of harm to self or others, or psychosis with risk of harm to self or others. So those are the cases where we would use medication first. And it should be noted that if somebody has a chronic serious mental illness like schizophrenia or bipolar disorder, just because they develop memory loss as an older adult doesn't mean you stop their medications. In many cases, we continue them, but we probably need to look at the dose as somebody ages to adjust that for different age-associated changes. So again, we're avoiding the knee-jerk use of medications, which can worsen symptoms, ignore the underlying cause of the symptoms. So if somebody has pain, we're not treating it by using an antipsychotic. It can cause unnecessary sedation and other side effects. And then it can worsen that person's quality of life and even cause mortality. So when you think about using medications, I also want you to think about who you are medicating. If you are medicating somebody, make sure it is not the caregiver, make sure it is not the anxiety of the staff, and make sure it is not the anxiety of yourself. And I will come back to that in a minute. And I think sometimes we are prone to use medications because we consider it very science-based. We are blocking receptors, and this is, very something that is, proven in studies. But it's not really the most evidence-based and patient-centered treatment. And in fact, know that medications show no efficacy in treating many of the symptoms our caregivers deal with, like repetitive questions or wandering or grumpiness or poor self-care. So a last thought about medications, again, avoid knee-jerk use. We want to do a targeted use. And we also want to expand the use of medications in behavior to think about things like pain. There was a study a number of years ago that empirically, meaning they didn't assess whether patients had pain or not. If patients had behaviors, they assumed they might have pain and that the behaviors might be an expression of that pain. And they treated them with a stepped pain control approach, which started with, because it was in the UK, the British version of Tylenol. And they found that by treating pain, they were able to significantly reduce behavior. What does that tell us? That much of pain and dementia is probably underdiagnosed, and patients cannot tell us about that. So patient-centered approaches need to ask about it. The other thing is that we often, with people who are older, prescribe pain control as needed or PRN. That is not helpful in people with dementia who may not know to ask for PRN. So scheduling pain medications may be more helpful. And we always want to think about assessing for other medical problems like constipation and infections. And we should also counsel patients never to stop medications without talking to their providers. So just to give you this little graphic, here is where we consider the use of medications in the DICE approach. On the describe step, we consider it when we cannot get a full description of the behavior because there is concern for harm or risk right away. In the investigate stage, we may use medications if we cannot fully investigate a behavior. For example, we can't get a urine or we can't even do vital signs. In the create stage, we'll consider medications if there's the presence of one of those three conditions, if it's depression, psychosis, or aggression with risk. And then importantly, in the evaluate stage, if we use medications, let's make sure that we assess for adverse events. So were there any side effects? Are symptoms still continuing? There was one study that was done a few years ago that found that in the VA hospital, older patients who were put on medications like antipsychotics a year or two later in the hospital were still taking them. Nobody had reassessed whether they needed them. And know that behavioral symptoms in people with dementia are a moving target. So what we see today may not be what we see next month. And so nobody should ever be put on an antipsychotic or a sedating psychotropic and not be reassessed for whether those symptoms are still occurring. Can we deliver the DICE approach without training? So this is one question I get because training takes a long time. And so in another grant, we looked at this. This is my collaborator, Laura Getlin. And we looked at creating an app on a web-based platform. We call it the We Care Advisor. And what we mean to do with this is basically put the DICE approach into this app so that without any training, caregivers can input their situation, the context, the environment, the behaviors that are occurring, and receive tailored suggestions. And those are some of the screens you see from the app there. So this kind of covers how we can help caregivers to use non-pharmacologic strategies, even without doing the trainings that we do. Within this app that I've talked about are contained over 1,000 strategies that get pulled from an algorithm depending on what the caregiver inputs. And the output of the prescription may look something like this. So that's great, but does it work? And in our previous trial, we found that we reduced caregiver distress, which is the blue line, significantly with only 1 month's use of the app. The orange line is the controls who didn't receive the app, but after 1 month got it. And what you see there is that their behaviors were largely static and then declined once they got the tool. We got tremendous positive feedback from caregivers that this was very helpful, that it helped them uncover unmet needs and medical issues. They love the feeling of support. It also includes a caregiver support guide, which includes tons of information on dementia, as well as provides a daily supportive tip to caregivers. And so what we did is applied for a larger grant, and we're now testing the app in over 300 caregivers. And we're very excited that to date, we've enrolled almost half of our study goal, so over 170 participants. And we've done it in a nationwide way. So over 31 states are represented so far. And I hope that I will soon have data to report from that study for you. So I'm going to end with a summary of what I just said, and then I'm going to end on a little bit of a personal note. I hope I've impressed upon you that the number of people with dementia and their caregivers is really growing every day with the aging of the population, and that we want to get beyond people existing and surviving, but living well with dementia. And that unfortunately, our current care systems are a bit like islands that are not connected by bridges. And so we need to help caregivers with innovative solutions to put good dementia care at their fingertips. While the new medication may be helpful for some people with agitation, and again, sometimes medications are helpful, we are concerned that we not use these medications in a knee-jerk fashion. So I just want to end on a personal note. And I can send this to Dr. Benlin and Cheryl if you'd like. These are just some resources in terms of the DICE approach, the ability to connect with our We Care Advisor study, and then our caregiver manual that are all available at these links. So lastly, on a personal note, I am currently in Florida. I did not expect to be here when I agreed to do this lecture, and that is my father. This lecture has incredible personal meaning. My dad has some cognitive impairment, and about a week ago, developed a series of medical issues that were nearly fatal. My brothers and I, so I very much appreciate the Kaufer family and the sibling teamwork, have basically come here in succession over the past week and a half, and saw my dad from the ICU to the floor, and now he is in the rehabilitation center. That's my mom. And what I'm very proud of is that you might say to me, you know, you talk the talk, but do you walk the walk? My dad has had numerous symptoms. He's been very delirious. And I'm very proud that we have not given him one psychotropic medication. And we talked to the ICU folks when we got there, and they said, oh, we use non-pharmacologic strategies. And I think the key is he has had incredible nursing care. In the ICU, they reoriented him, they calmed him, they, gave him a lot of natural light. The family has been doing a lot of, you see there, I created a little whiteboard for him there with his schedule, and then I created a picture board for him. And I'm happy to say that, his delirium seems to be resolving. So I really do practice what I preach, and hopefully now we can end on that note and maybe take some questions, Dr. Benlin, if we have a few minutes.
Thank you, Dr. Kales, for a fantastic, phenomenal lecture with so much useful information. And also thank you for sharing your personal story and for joining us today. We so appreciate it. It makes, this is just so meaningful for us. Thank you so much. We are open for questions. Chat is disabled, but Q&A is functional. So please go ahead and drop your questions in the Q&A. I could start us off. I'm really impressed by all of your work, of course, but also thinking about the challenges of dissemination and how you've used, how you've developed this app. And I'm also wondering, what do you think, what else is needed to disseminate this approach and make it more widespread? whether that's an advertising campaign or, how do you reach people? And then also, have you thought about offering this in different languages?
That's a great question. So I think a lot about this. I actually talked to one of the heads of CMS and the National Policy Initiatives for Antipsychotics a few weeks ago about the need to, antipsychotics have been used as a marker of quality, or the degree to which a facility has low use of antipsychotics has been used as a marker of quality. So the 5-star rating that the CMS has, that is one of the markers. And we've urged CMS to really go beyond this. And I think this will resonate with the Kaufer family, is to think about how we measure person-centered care and thinking about ways that we can codify that. So we're really truly measuring what a nursing home or facility does. And I'm so thrilled with the place my dad is now. It's not the poshest place or the best place in terms of, again, Hyatt Regency style, but the people are what makes it, and the staff is what makes it. And so I think when people, what I always talk to families about is look for that approach, ask them how they handle behaviors. I think that, a lot of the facilities that look a certain way may not be as trained on behaviors as we would think about. And sometimes you even talk to a facility, and what a dementia unit is they have a lock on the door. That's all it is. That is not memory care. That is not expertise in memory care. So we really need to promote that. I do a lot of interviews. I just did one for one of the neurological publications that is like a clinical psychiatry news, but for neurology, talking about, again, it's not using medications, but it's using them as a physician. We were trained as physicians. Use your expertise, use all of your skills. And often some of the best strategies will come from our frontline folks, like family caregivers, or because they know the person and they can tell us what they liked and didn't like, or what, I know my dad, he's a very intellectual guy. We're bringing the IBD, or investors, I think it's Investors Business Daily. And I'm, he's not investing in stocks right now, but we're talking about it, right? Because that's what he likes. And so in terms of other languages, we have been approached by many, many countries, and we would love to think about that. It's often an issue of funding because we want to make sure we get it right. And translation and culture is very, very important.
So, Dr. Kales, we're getting quite a lot of questions in the chat now and in the Q&A. So the first one is brexpiprazole a strong D1 inhibitor, so not good for Parkinson's disease, agitation, dementia?
So, I'll confess that I don't know the answer to that. I, unfortunately, there in the material that was put out, there wasn't a lot about mechanism. And so I think that we have other medications. There's one currently, approved now for, pimavanserin, and, I would probably use that preferentially if we're thinking about Parkinson's disease and some of the other etiologies. What I would also say is that, again, in Parkinson's disease and Lewy body, although hallucinations are disturbing to everybody when they occur, and my own father was having them, recently, we need to think about whether they are truly disturbing and impacting function in our risk benefit. Because sometimes what you find, and I was always struck by this patient I saw a number of years ago, he was seeing vast displays of Christmas ornaments and Santa Clauses. And while the family found that very disturbing, he did not find it scary or disturbing at all. And so educating to them that this is something transient, this will probably go away in a few weeks, which it did, we were able to not treat him with a medication. So certainly if somebody is seeing something that scares them or really frightens them and is impacting their quality of life, that's a different story.
Very helpful. We have a question about PC teams. They have so many competing demands. In your pilot, how have you addressed limited time, not only for training, but also for their delivery of DICE?
That is great. And that's why this trial we're doing is truly, it's funded as a, real world efficacy trial. So there is no study personnel that is added. We're actually using actual clinic personnel and we're using their time. What we are depending on, and we do regular booster sessions with them, is the success stories and the word of mouth. And so recently we had one, and one of the LVNs told a story about a person who was wandering in the facility. And the primary care physician came to her and said, "Oh, you guys are using that DICE thing, do you want to maybe talk to this family?" And so they actually slowed clinic down and probably backed up clinic by a half an hour for everybody. But what they found out in that half hour was incredible. This woman at home was a gardener, and she was trying to get out in the facility to the garden area that they had to do some gardening. Once they found that out and they were able to structure for her daily visits to the garden, the wandering behavior stopped. And so what this woman, LVN, communicated to everybody is, yes, we slowed clinic down a little bit, but we saved this family potentially unknown heartache with medications and, emergency room visits and falls and those kind of things. And so that kind of success story, I think, really helps us. I do think, though, that the health system being excited by this trial and really promoting it as person-centered care that helps move our care team forward has helped a lot. Without that, I think it's very difficult. I will just be honest, there's a medical hierarchy and often there are so many demands. So I think we just have to move to a different place with our care.
Wonderful. Thanks for sharing that example. Have you noticed if there is a difference in response to DICE between men and women caregivers?
That is interesting. I think we did not have enough numbers in previous work to really, and as everybody probably knows, our caregiving field, if you want, is probably predominated by women. At Michigan, one of the things that we learned about when we were developing DICE was there is a really good book for men, and I'm probably going to mangle the title, but I think it's available on Amazon. And it's called The Coach's Playbook for Men, I believe. And it's written by a former football coach. And he puts a lot of this into, and I don't want to be too gendered, but for the age of some of the cohort, some of our male caregivers are in, he puts it more into their terms and thinking about marshaling resources as sort of a coach and leader of a team. And we found that for men, and particularly we had some work with the VA hospital, that was very helpful to think more about those things. I think the other thing is a lot of the activities we create in a lot of facilities can be a bit more gendered in terms of art, crafts. And we really try to think about, and again, I'm in no way saying art is for women, but we don't tend to think about what did a man like, what was he interested in. My dad would not do a craft if you hit him over the head with it. I mean, that's just not who he is. And so again, thinking about what the interest of that person is. And my colleague, Dr. Gitlin, often gives the example of, let's say somebody was a fisherman, but he can no longer do that. You might think about fishing themed activities. So early on in dementia, it might be sorting flies in a tackle box. And later on, it might be watching a fishing video, but you really want to incorporate those interests. I think that one of my least favorite things is when I'm rounding on a unit and I see like a music therapy group and they're all singing the same song. And I think our musical tastes are so varied. Why are we all singing the same song. That doesn't even make sense. And it feels to me like if I went into a place, that could be a form of torture, depending on the song. So we really want to think about, tailored music. We had an Italian immigrant who was interested in opera. What do people like? What are their likes and dislikes? What really gets them excited? And so that's the kind of thing. And once we start brainstorming with people, it just burgeons, and it's really fun.
Yeah, wonderful. There was also a question about whether there's any race, and this is from Dr. Stana, whether there are any race or ethnicity-based differences in the implementation or outcomes of DICE.
So we're looking at that in our current trial. Interestingly, in our first app trial, Dr. Gitlin at the time was at Johns Hopkins, and so largely our study sites were from Baltimore, and we had a large number of African Americans. And what we found was this pretty much was universal, that the need to manage behavior, especially if you think about, for many of our current older generation, they're sandwiched between sometimes children and grandchildren and then parents. I myself, my son just graduated from high school on Friday, and then I was flying here tomorrow. So we're all kind of juggling these sort of life events. And so I think that across the races, across ethnicities, we're coming up with the same kind of things. I think one of the things that we consider in DICE that I think has been so effective is, how does the culture impact on expectations? And I think that's one of the things that in certain cultures, there are high expectations on our elders, and sometimes we really have to think through those, and whether a big family gathering, for example, will be really fun for that person, or whether it will be stressful and overstimulating. And so we may want to think that through and sort of problem solve ahead of this time as to, well, maybe a half an hour of this, and then we do something else. So just kind of incorporating that.
All right, we have time for just a couple more questions here. Of course, also getting lots of accolades about what a wonderful talk this was. I think that a lot of what you talked about today in terms of DICE and non-pharmacological approaches can be tailored to most patients. But I was wondering if you had any additional thoughts, considerations when caring for patients with specifically early onset Alzheimer's disease and perhaps other early onset dementias, given that these individuals are at a different stage of life compared to individuals who develop dementia later in life.
Absolutely. I love that question. And I think the biggest thing I would say is, when people get a diagnosis of dementia, often what happens is they stop talking to the person. People stop directly addressing the person with dementia, and they start looking to the family or to the partner or to, whoever's in the room. And I think early on, there's a lot that can be done in terms of therapy, but also thinking about, and I firmly believe this, I believe that we can change the trajectory of dementia. We think on the Lancet panel that up to 45% of dementias could be prevented through lifestyle changes like treating hearing loss or addressing depression. And it goes to reason that we might be able to change the trajectory of dementia even once it occurs. Let's say it's due to vascular disease. Well, if we arrest that vascular disease, we could potentially prevent somebody from progressing to later stages. So I think working with the person with early onset dementia in the DICE approach, but not through the caregiver, more through them, and with the caregiver maybe as a partner, equal partner, and really thinking about activity as it pertains to physical, mental, and social activity. Those are sort of my holy grail. I think those are what we want to really work on when somebody has early dementia. It is not the end, it is the beginning. And we really want to work on making life as good as possible and really maximizing what that person can do.
Thank you. The last question is whether the app is available for download and use, and where can people find that?
So the app is not yet available for download and use outside of the trial, but and I'll send the links to Cheryl and Dr. Benlin later. If you know of caregivers who would like to try, we still have the same conditions. You either get randomized to the app itself right away or a 1-month waiting period, and then you get the app. So either way, you'll get the app. And then we hope that it will be available very soon after the trial. We're really excited about it. One of the things that I just want to leave people with, because this is something we can all do in our own lives, is that I was pretty non-enthusiastic about the daily support messages when we included them. I just sort of, it was a suggestion from our support groups that we do it and our focus groups, but that is actually one of the favorite features of the app, that people who are doing this type of caregiving work, and we'll call it work, need that daily support. And I certainly know it this week. You need that. You're doing the best you can, keep going, because, you know, there's often that self-doubt or guilt, or, you know, if you had a difficult relationship with somebody. And so just receiving that support means a lot. And so I would say, let's all do that for each other, because we all know somebody who's a caregiver, and just that one intervention, that regular support, can help people so much.
Thank you, Dr. Kales. So I truly want to thank you for joining us today and providing so much valuable information, and for sharing your personal story and just making this lecture very special for us. I'd like to thank the family of Daniel Ian Kaufer for starting this Endowed lecture. We appreciate the family and Dr. Kaufer's wishes to share his legacy with the UW-Madison initiative to end Alzheimer's, as well as future researchers and clinicians. I want to thank everybody for joining us today, and thank you to Dr. Kaufer's family and friends. Thank you again, Dr. Kales, and everyone for joining us today to honor Dr. Kaufer. Thank you.
Thank you. Bye.